If you take Amlodipine, Losartan, or Lisinopril every single morning, I need you to answer one question honestly. Do you actually know what that pill is doing to your heart, your kidneys, and your nervous system right now? Not what the bottle says, not the one sentence your pharmacist printed on the bag. I mean the mechanism, the way it shifts, the warning signs that separate a manageable nuisance from a situation that needs immediate medical attention. Most people pause when I ask that. Educated people, careful people, and that pause tells me everything. These are not vitamins. They are powerful medications that rewrite how your blood vessels, your heart, and your kidneys operate every single day. Yet millions of seniors take them on autopilot, ignoring the signals their body is sending, making quiet mistakes that cost them their independence. Today, that stops. I am Dr. Raj Patel, 15 years in clinical practice, and this channel exists for one reason: to give you the clear, practical, honest health information that too often gets left out of a 10-minute doctor's appointment. By the time this video ends, you will understand exactly how your blood pressure medication works. You will know the side effects that are normal, the ones that are dangerous, and the exact steps to take when something feels off. I am going to break down Amlodipine, Lisinopril, and Losartan. I will show you the hidden interactions most seniors never learn about, and I will give you a safety plan that keeps you from being caught off guard. Stay with me through every section, because the warnings I give you in the middle of this video are the ones that save lives. Let me start with a patient named Emily, 68 years old, sharp, meticulous, former project manager. She took her medications exactly as prescribed, never missed a dose. When her doctor added Amlodipine to her regimen, she figured one more blood pressure pill. Same category, different name, no big deal. That assumption almost cost her a year of her life. 3 months later, Emily could not fit into her regular shoes. Her legs felt heavy by 4 in the afternoon. She started limiting her walks. She told her daughter she thought her heart was failing. She went online and started reading about congestive heart failure. The real answer was far simpler. But she did not know it because nobody ever explained to her that these 3 drugs are not the same. They all lower blood pressure. That is where the similarity ends. Amlodipine is a calcium channel blocker. It relaxes the smooth muscle inside your arteries so blood flows with less resistance. Lisinopril is an ACE inhibitor. It blocks an enzyme that tightens your blood vessels. Losartan is an ARB, an angiotensin receptor blocker. It works on the same system as Lisinopril, but through a different receptor. 3 different mechanisms, 3 different side effect patterns, 3 different things you need to watch for. When you understand which door your pill opens, you stop misreading your body. Emily's swelling was not heart failure. It was amlodipine doing exactly what amlodipine does. And once that was identified, she was back in her walking shoes within weeks. Let us talk about that swelling specifically, because it is one of the most widely misunderstood side effects in blood pressure medicine. When amlodipine relaxes the small arteries in your legs, blood flows in more freely. But the veins, which carry blood back up to your heart, do not relax at the same rate. You get an imbalance, more blood entering than leaving. Pressure builds in the tiny vessels near your ankles. Fluid pushes out into the surrounding tissue. The result: puffy ankles, socks that leave deep marks, shoes that stop fitting, legs that feel heavy by late afternoon. This is not from eating too much salt. This is not your kidneys failing. This is not heart failure starting. In most cases, it is a predictable physiological response to how the drug works. Here is where it becomes genuinely dangerous. Not the swelling itself, but how people respond to it. Some people see the swelling and stop the medication without telling anyone. Their blood pressure climbs back up quietly while they feel like they made a sensible decision. Others start restricting water because they believe they are retaining fluid. That is the wrong direction entirely. Dehydration on a calcium channel blocker carries its own risks, and some people, like Emily, simply endure in silence for months, reducing their activity, assuming the worst, losing quality of life unnecessarily. The right move is this. Leg swelling on amlodipine is a conversation your doctor needs to know about. Not because the drug is necessarily wrong for you, but because there are adjustments. Timing the dose differently, leg elevation strategies, or switching to a different class entirely. None of those options happen if you suffer in silence. Now let us move to Lisinopril and the most notorious side effect in the ACE inhibitor family, the cough. Not a wet cough, not a productive cough. A dry, scratchy, relentless tickle in the back of your throat that gets worse at night and does not respond to cough drops, antihistamines, or anything in your medicine cabinet. Here is what makes this one so tricky. It often does not start immediately. Some people develop it within a week. Some take 3 or 4 months before it appears. By then, the connection to lisinopril never crosses their mind. They blame dust, allergies, a lingering irritation after a cold, acid reflux. I want you to meet Kate, 72, active gardener. Assumed her cough was from pollen season, used antihistamines, bought an air purifier. Her primary doctor ordered a chest x-ray that came back clear. 6 months later, the cough was still there. Her sleep was ruined. She was exhausted, irritable, and starting to believe something serious was being missed. When she came to see me, one of the first questions I asked was when she started lisinopril relative to when the cough appeared. She went quiet, pulled out her phone, started doing the math. She had started lisinopril 10 months earlier. The cough appeared 4 months into treatment. She had never made the connection. Once we worked with her doctor to switch to Losartan, which targets a similar pathway but does not trigger this reaction, the tickle was gone within 10 days. 10 months of disrupted sleep resolved in less than 2 weeks. Once someone connected the dots. I need to draw a hard line here. Because there is a symptom in the ACE inhibitor category that is not a nuisance. It is a medical emergency. If you are on lisinopril and you develop swelling of your lips, tongue, face, or throat, especially if swallowing or breathing becomes difficult, you do not wait. You do not call the office tomorrow. You do not take Benadryl and see what happens. You call emergency services immediately. This is angioedema. It is rare, but it is real, and it can close your airway faster than you expect. A dry cough is a nuisance. Throat swelling is an emergency. The gap between those two is a matter of minutes. Please burn this into your memory. Now let us talk about Losartan and a danger that strikes me as particularly frustrating because it does not come from doing something wrong. It comes from people doing what they believe is the right thing. Losartan, like lisinopril, works on your body's blood pressure regulation pathway. One of the effects is that it can raise potassium levels in your blood. For most people, this stays within a safe range when monitored, but add certain common lifestyle choices on top of it, and the picture changes. Potassium does not just come from bananas or supplements. It is hiding in products actively marketed as the healthier choice. Salt substitutes, Many low-sodium alternatives sold right next to regular table salt replace sodium with potassium chloride. A senior who has been told to cut back on salt buys the substitute, uses it liberally on every meal, and is now loading potassium into their system while taking a medication that already raises potassium levels. The combination can push potassium high enough to disrupt the electrical system of your heart. And here is what makes it dangerous. High potassium does not always announce itself loudly. It sometimes shows up as unusual muscle weakness, persistent fatigue, cramping in the legs, tingling in the hands, or a fluttering, irregular heartbeat. Sometimes there are almost no symptoms at all, right up until there are serious ones. Think about someone in your life who switched to a salt substitute in the last year. If that person takes Losartan or Lisinopril, this is a conversation that needs to happen with a doctor, not because the medication is dangerous in isolation, not because potassium foods are harmful, but because the combination without awareness can create a slow-building problem that never needed to happen. Electrolyte powders, meal replacement shakes, and certain sports recovery drinks also carry meaningful potassium loads. They are not prescription products. Nobody thinks to mention them. That is exactly why they matter. There is one scenario that does not get nearly enough airtime in conversations about blood pressure medications, and it affects seniors more than any other group. What happens to these drugs when you get sick? Not hospitalization, just a bad stomach bug, a few days of vomiting, diarrhea that will not quit, loss of appetite, or simply a hot week with heavy sweating and not enough fluid intake. When you are dehydrated, the same dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated body acts dramatically differently. Your blood pressure can fall too low. Your kidneys, already working harder due to fluid loss, become vulnerable. Dizziness, weakness, faintness, or acute kidney strain can develop faster than most people expect. The medication did not change. Your body's internal environment changed, and the drug is now operating in conditions it was not designed for. Illness changes the rules. If you do not have a plan for what to do when illness hits, whether to hold a dose, when to call the doctor, what symptoms should trigger a visit, you are leaving a significant gap in your safety. That plan is something you should have from your prescribing doctor before you ever need it. If you do not have it, ask at your next appointment. What should I do with my blood pressure medication if I get a stomach virus or cannot keep fluids down? It is one of the most important questions you can ask, and it is one of the least commonly asked. Let me paint another scenario. You have a bad week. Arthritis flares, knees ache, back stiffens. You head to the drugstore and pick up ibuprofen or naproxen, something you have used for years, perfectly ordinary, over the counter. Now you are taking Lisinopril or Losartan. Maybe you are also on a diuretic. This combination, when used regularly, can meaningfully reduce blood flow to your kidneys. In the context of even mild dehydration, the risk of kidney injury rises substantially. This is not a hypothetical, rare scenario. It is one of the most common, most preventable situations I see, and it slips through because patients do not think of ibuprofen or naproxen as real medications in the same category as prescriptions. They are just something from the shelf. Your kidneys do not distinguish between prescription and over-the-counter products. They respond to chemistry. If you routinely use anti-inflammatory pain medications for joint pain or back pain while on these blood pressure drugs, have that conversation with your doctor. There are often safer alternatives: acetaminophen, topical treatments, physical therapy approaches. You do not have to endure the pain, and you do not have to silently accept the kidney risk. There is usually a better path. You just need someone to help you find it. I want to spend a moment on something that sounds small and absolutely is not. Dizziness. That brief wobbly moment when you stand up from the couch or get out of bed in the morning. The world tilts for 2 seconds. You grab the door frame, it passes. You go about your day thinking you just got up too fast. For many seniors on blood pressure medications, this is a regular experience, and it is almost universally underreported because it seems too minor to mention. Here is what I need you to hear. In older adults, 2 seconds of dizziness is enough to cause a fall. A fall is enough to cause a fracture. A hip fracture can derail an older adult's health trajectory in ways that take years to recover from, if recovery happens at all. The dizziness happens because your medication is doing its job, lowering blood pressure. When you stand quickly, your cardiovascular system has not had time to compensate. Blood pressure drops briefly. Blood flow to the brain decreases. You feel it as a lightheaded tilt. The fix is often simple. Rise slowly. Sit on the edge of the bed for a moment. Hold on to something stable. Give your body 10 extra seconds to catch up. But beyond the practical adjustment, dizziness that happens regularly or an episode of near fainting deserves a real conversation. The dose may need adjustment. The medication combination may need review. Hydration habits may need to change. Silence on this issue is not a small risk. Let me address something that creates enormous, unnecessary anxiety and occasionally dangerous, impulsive decisions. Blood pressure is not a fixed number. It moves constantly throughout every hour of every day. How well you slept, whether you had caffeine, if you are in pain, whether you are anxious about the reading itself, whether you just walked in from outside. A single high reading on a Tuesday morning after poor sleep does not mean your medication is failing. A single low reading after sweating in the heat does not mean your dose is too strong. What matters is the pattern over time, measured consistently, same arm, same time of day. After 5 minutes of quiet rest without rushing or talking. When people monitor inconsistently and react emotionally to individual readings, the decisions that follow are almost never good ones. Extra doses taken out of fear. Skipped doses because one reading looked good. Frantic calls about a number that, in context, was completely unremarkable. Monitor with a method. Track over time. Bring the log to your appointment. Let patterns guide the conversation, not panic. That simple shift reduces anxiety, improves decisions, and gives your doctor far more useful information than a single alarming screenshot from a home monitor. These medications work through steady, consistent presence, not spikes and gaps, not extra doses when you are worried, not skipped doses when you feel fine. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are designed for daily rhythm. Take control. Know your drug. Watch your body. Ask your doctor the hard questions before you need to ask them in an emergency room. Your health is too important to manage on autopilot. Everything shared in this video is based on published clinical research and is intended to inform and empower you. It is not a substitute for professional medical advice. Always consult your physician before making changes to your medications, diet, or exercise routine. Your healthcare team knows your history, your lab work, and your full medication list. They are the only ones qualified to adjust your care safely. I am Dr. Raj Patel. Take care of yourselves. I will see you in the next video.